Good afternoon. Let's see. Good afternoon. We're going to talk about the techniques for difficult colonoscopy and preparation. But first, let me talk about preparation. I think any vigorous cathartic will do for preparation. There are multiple preparations out there. There are 2-quart preparations, 2-liter preparations, 4-liter preparations. There are smaller preparations. There are smaller preparations. The one that we used, the preparation that we used to use all the time was phosphosoda, which was very good, but it caused renal failure in some patients, so we don't use that anymore. And then there's the 2-quart preparations, Miralax half-lightly. Citrated magnesia is the one that I use, which is 2 doses of 10-ounce bottles of citrated magnesia before the preparation. And then there's the standard 4-liter preparation. But of all the preparations that one uses, I think that split dose is the way to go. Everybody now espouses split dose. That is, you must take the second portion of the dose somewhere around 4 to 6 hours prior to the procedure, because the second dose is the one that cleans the patient out well. So for most of these procedures, we use a split dose preparation with 1 dose given the day before the procedure and 1 dose given about 4 hours prior to the procedure itself. So the preparation is not vigorous. Most of us have been brought up on the clear liquid diet aspect of the procedures, but I think that we don't need a clear liquid diet. The cathartics are so potent that they clean everything out of the colon. So for me, I give the patient milk, cheese, ice cream, and they can have clear liquids as well, but there's no reason that you can't have a milk product because it gets cleaned out by the preparation. So let's go on to the difficult colonoscopy. How do we do that? We want to go from a colon that looks like this to a colon that looks like that. And now, how do we do that? The way to do that is to observe the patient beforehand and decide what you have to do when you see the patient. It's difficult in the left colon in patients that have pelvic surgery, severe diverticulosis, or slender women. Slender women are especially difficult because not only do they have a smaller abdominal cavity than men, but they also have extra organs in the abdominal cavity that makes colonoscopy somewhat more difficult. Besides which, a long time ago, Christopher Williams did a study with his radiologist, Dr. Bartram, and he found that the colon in women is longer than the colon in men. So it makes for an especially difficult colon. So I think that the left colon is where you're going to get in trouble with patients that meet these criteria. How about in the right colon? In the right colon, it's difficult when you run out of scope, and that's in tall men or big fat people. So these are the groups that you're going to run out of scope with, and you need a different scope for these than you do with the slender women. So there's different scopes for different colons, and the standard colonoscope is one that everybody uses. The pediatric colonoscope is my favorite colonoscope for general colonoscopy, and if I really have a difficulty in the left colon, I'll use a gastroscope. So I think that you have to tailor the instrument for the procedure. If you can't pass the sigmoid, use a gastroscope, and it usually gets to the cecum. If you run out of scope, use an adult scope, one of these that are more sturdy. And if you still run out of scope, use an enteroscope. So I think that there's different instruments that you have to use when you get in trouble with various types of procedures that you're going to do. Well, what do I do with an impossible sigmoid colon? You can't get out of the sigmoid colon, and then you should torque, jiggle, use abdominal pressure, try to straighten the colon, put the patient supine on their back. The variable stiffness isn't worthwhile to use when you have a difficult sigmoid colon, because the variable stiffness aspect only comes into play after the first 30 centimeters of scope. So when you have a difficult sigmoid, it's usually you run into trouble somewhere between 20 and 30 centimeters of instrument inserted. So the key is to use a gastroscope. And you can almost always reach the cecum when you have a difficult sigmoid colon, because whatever caused the sigmoid colon to be difficult and fixed, once you get by the sigmoid, it will act as a stent to keep the colonoscope or the gastroscope straight once you're through the sigmoid colon, and that allows you to get to the cecum almost all the time when you use a gastroscope for a difficult colon. On the other hand, if you use a gastroscope for a regular colonoscopy, you can't anywhere near reach the cecum because it just isn't long enough. So you need to pull back a lot and often, and you may need a stiffening wire if you use a gastroscope in the right colon. So what about water colonoscopy? Well, if you're going to use a lot of water, you turn off the air, you fill the colon with water. I have found that the patients often leak when you use the water colonoscopy, and you got to watch out for your shoes when you do a colonoscopy with a colon full of water. However, frequently I'll use some water trying to get by the rectosigmoid, because in the patient with a left lateral position, if you give water, it may weight down the sigmoid colon and straighten it out to make passage through the rectosigmoid much easier. Well, looping is the enemy of colonoscopy, and looping occurs in over 90% of examinations. You can loop in the sigmoid colon, or you can loop in the transverse colon. However, experienced colonoscopists are rather poor at identifying where the loops are being formed. However, by pulling back, torque, and abdominal pressure, loops can be eliminated and then prevented. So I think that all of us make loops, but we can pull back and torque and get rid of the loops, and then use abdominal pressure to prevent loops from happening. There is a technique for identification of where the loops are in the instrument by using a magnetic imager called the scope guide. All adult-sized colonoscopes are made with magnetic chips embedded in the colonoscope from Olympus. And by using a special image and electromagnetic coils, one can actually reproduce the configuration of the scope just as if you were using fluoroscopy. But it doesn't use fluoroscopy, it's magnetic imaging, and you can see where the loops are in the instrument and therefore take them out. This is a depiction of what you're looking at. This is the loop in the sigmoid, in the rectosigmoid area, as is this, and you'll see that that's very anterior here. This is the loop in the transverse colon, and that's also very anterior. And these make a difference in how we're going to approach the patient, because there are two places where the colon, actually three places where the colon is very anterior. One is the rectosigmoid, one is the transverse colon, and the other one is in the cecum. So these areas here can be readily depicted by using scope guide. I've tried scope guide. I think it may be worthwhile. I think for beginning practitioners, it's very worthwhile so they can understand where the loops are being formed. So there's multiple areas where loops are formed, and this magnetic imager may tell you where they are and help you to straighten them out. Well, what I do with an impossible right colon, if you can't get beyond the hepatic flexure, it's often in tall men or really fat people. The scope loops, you can't straighten it out no matter what you do. You may push the entire scope in and you still can't get beyond the hepatic flexure. So in those patients, you have to use a stiffer scope. And that usually means an adult scope or a double channel scope. And you have to pull back a lot and remove the loops once you pull back, you almost always have a loop outside the patient. It's very important to take the loop that's outside the patient and restitute that loop so that you will straighten out the colonoscope inside the patient. So it's very important to remove the outside loop once it's formed, otherwise you cannot keep going with the colonoscope. Abdominal pressure is worthwhile. Supine position is sometimes helpful, and rarely do I put patients on their stomach. So if everything else fails, pull back the sigmoid colon and retry again, and that can almost always result in a successful colonoscopic procedure, and then use an endoscope if you just can't make it. So these are the patients that you really have trouble with the right side of the colon. So I think the most basic important technique is pull back to straighten the scope. Whether the patient is skinny, fat, tall, post-op, has adhesions, you have to pull back to straighten the scope. And you cannot do colonoscopy with big loops in the scope. You must try to pull back to straighten as much as you can. So what happens is, if we have the scope in this configuration and we push, we'd like to go further forward, but what usually happens is you push up toward the diaphragm. And then once you hit the diaphragm, then you keep pushing and the scope will go forward. But that's not a happy circumstance. What you really want to do is to go in a little bit, pull back the scope to straighten it. Every time you push the scope in, the sigmoid mesocolon makes you obligatorily have a loop in the scope. So you make a loop in the scope, you push a little bit, then you pull back again to straighten out the loop, and you can keep going. So I think each advance will create another loop, and you have to pull back the shaft to straighten. So that's the first basic procedure for colonoscopy. The second basic procedure has to be using abdominal pressure. And I must say that most endoscopists don't use abdominal pressure correctly. Abdominal pressure tends to keep the scope straight. It stops you from making big loops. It may move the tip forward, or it may move the bowel over the tip of the scope. We don't know which way it's doing, but it does aid to increase the speed of the examination. So here, as I mentioned to you before, if you push, it's going to go up toward the diaphragm. You really want the tip to go forward, but it won't go forward. So what we really want to do is to pull the scope way back. Instead of having the scope at 60 centimeters inside, pull the scope back to 20 or 25 centimeters. It's like this. Then you use abdominal suprapubic pressure just over that very anterior portion of the suprapubic area. So this becomes very anterior, so abdominal pressure helps. So now you push, and you're going to push it, and the scope will hit against the hand of your assistant and will tend to go forward. And here's where the patient, you can have your assistant give abdominal pressure at 25 centimeters. It's, remember, this is very anterior, this is posterior, but this will help to get through the difficult sigmoid colon. And what are we actually doing with abdominal pressure? Well, in the right colon, if we push here, we may push the colonoscope, push the colon over the scope. Or we may be pushing and push the scope actually further into the colon by pushing here. So whether we push here and straighten the scope and push it further in the colon, or whether we push the colon over the instrument, we're not sure which one works, but the important part of abdominal pressure is to give pressure in a place that will advance the scope. And the fact is that you have to find the place to give abdominal pressure. I hear many doctors say, okay, to the nurse, give abdominal pressure. And then I hit them on the arm, and I say, that's not the way to give abdominal pressure. you have to find the place to give abdominal pressure unless it's suprapubic pressure. Then you use left lower quadrant pressure, and that will usually help to advance the scope. Okay, so abdominal pressure is important. I think you have to learn to use it. I use it in almost every case that I do. And if it's at 15 to 20 centimeters, use deep suprapubic abdominal pressure. If it's at 25 to 40 centimeters, I use left lower quadrant abdominal pressure. And beyond the splenic flexure, then you have to find the place to find it, to use abdominal pressure. Reach over the patient, press in several places, and your objective is to advance the scope. And by using abdominal pressure, advancing the scope under direct vision on the screen, have your assistant replace your hand with their hand, and then you put your hand back on the scope, and you can almost always advance the instrument. The third most important maneuver in colonoscopy is to aspirate air. And the fact is that it decreases the length of the colon, it decreases the circumference of the colon, it does help to advance the scope, and can be a great help in getting around a corner that's just a little bit further around and you just can't get there. It really doesn't do anything to relieve patient discomfort, but it may help you to advance the scope. So if you look at this, here is a balloon that's deflated. It's 11 inches long, but the balloon inflated is 40 inches long. So in order to get a little bit further in the colon, if you take the air out, you can make a long colon much shorter and advance, have the scope advance just by taking out the air. The same thing here. Here's a balloon that I inflated, and it's much bigger than the rule. And when you take the air out, it becomes much shorter. So it not only decreases circumference, but it also decreases the length of the colon. And it's very helpful. But I think that's one of the important aspects of doing colonoscopy. So the algorithm for colonoscopy in a difficult colon is if you have a difficult colon, this was by Doug Rex in gastrointestinal endoscopy. If you have a difficult sigmoid colon, use a pediatric colonoscope, or I use a gastroscope often, use an ultra-thin colonoscope, an upper scope, or a double balloon enteroscope. And then he talks about a guide wire exchange. If we have difficult colonoscopy with a redundant colon, that's usually in the right colon. You go to good basic technique, that's to pull back, aspirate air, change the patient's position, use a colonoscope with an overtube, a push enteroscope with overtube, or double balloon. So I have modified this. For me, for the difficult colonoscopy, a difficult sigmoid, I frequently will go to an upper endoscope. The one I use all the time is a pediatric colonoscope. Go to an upper endoscope, and that'll almost always go through because you want this acute tip angulation. I don't use a guide wire exchange. I don't use the double balloon enteroscope. Sometimes I use an ultra-thin colonoscope, but it's very floppy, and you may need a guide wire with that. In the redundant colon, which is usually in the right colon, I think good basic technique, a stiff scope or a push enteroscope. I don't use an overtube. I never use an overtube, and I don't use a double balloon enteroscope. So I think that you have to work at it, continue to pull back, use abdominal pressure, and remove air. These are the most important aspects of doing a difficult colonoscopy. Be sure to have a clean colon. I think the important thing is the patient has to be well cleaned out in order for you to perform a successful colonoscopy. Pull back a lot and pull back often. Every advance you make will make an obligatory loop in the colonoscope because there is a spiral loop that forms from the attachment of the mesocolon and the sigmoid colon. So every time you advance the scope, you're going to make a obligatory loop in the sigmoid area. So you have to pull back to straighten the scope so that the torque, the force vectors will be aligned with the straight scope and allow you to advance the instrument. Use abdominal pressure or position change often. I think most of us don't think of changing an instrument And I think that if you have a difficult sigmoid colon, change to a gastroscope. I change very readily to a gastroscope if it's difficult to get through the sigmoid colon, because sometimes the bend of the tip of the colonoscope is just too wide to go through a very tortuous and fixed sigmoid colon, either in women that have had pelvic surgery or men with severe diverticular disease. It's much easier to go through with a colonoscope. If the looping is the problem, use a stiffer colonoscope and pull back often. The fact is that you can get there most of the time using standard instruments and standard techniques. You don't need something very special to get through the colon. It just takes a lot of work sometimes, but you can do it if you try. Thank you.
Thank you, Professor Jerome Waye, for your excellent presentation, for the many tricks and secrets we have learned from you. We hope that from tomorrow we will have only successful colonoscopies up to the terminal ileum. Thank you. Questions at the end of the session. The next speaker.